Okay, so thank you very much for attending the course. I remember the course very fondly from the time I was a trainee, so hopefully you have had an equally good experience over the course of the last month. Um, Thank you for participating. I know we've really worked hard to try to make the course interactive and use the chat function to allow lots of question and answer time throughout the course. So hopefully you have appreciated that. I know we appreciate as teachers the interactions that we have with you online. And then most importantly, thank you for submitting cases. We know the hard work that goes into finding the cases, getting all the components of the case, especially the pathology, and getting them submitted either before or during the course. Uh, we take those cases that came to us and we evaluate them all very carefully. We try to learn everything we can from them in conjunction with pathology colleagues. And then we try to repackage them as part of lectures or papers to benefit the whole radiology community. So you putting in that hard effort to get the case together and submitting to us will hopefully help future radiologists who come through the course. Okay, so thank you for taking the time to do that. The second thing I want to just highlight is that we've partnered with the new Rankin Ray journal called R3 or Rankin Ray Review to release some special issues containing best cases that winners, examples of best case winners from the AIRP. Okay, so if you happen to be selected, your case is selected as a winner, please consider contributing your cases to that. We would reach out to you at a later date if your case is selected to potentially be involved in this special issue. Okay. And then finally, for all the section chiefs that are on, I just here's the presentation order for today. I'm assuming you're going to share your own screen unless you tell me otherwise. Okay. Now, is Dr. Manning on?
Anybody see her?
Not yet.
Okay. Well,
Do you, if she doesn't join Jamie, since I'm next, do you want me to present? I can do that.
um, no, that's okay. No. I just wanted to say a couple words about Dr. Manning, but we'll wait for her to come on. So if anyone can
Okay.
alert me when she comes on, that would be great. Okay. Okay, so we're going to move on and I'm going to do the first case, which is going to be the GU case. Um, so the GU case, there were many submissions today or this course, and I think I narrowed it down to about 10. It was so hard to choose the best one. Okay, so if yours didn't get selected, doesn't mean it was an awesome case, but I had to pick one. Okay, so the case that I did select was a case of a 68-year-old man who presented with a palpable penile mass. Okay, it went on to biopsy, and that biopsy revealed a poorly differentiated carcinoma that was thought to be consistent with a primary penile cancer. Okay, this led to further imaging with MRI, and here we see T2 weighted images, and you'll see that there is a mass here, which is eccentrically located within the penile shaft. It shows intermediate T2 signal intensity. It's that ugly, evil gray of tumor. But notice that instead of being at the distal aspect of the penis where the mucosal surface lives, instead it's at the level of the corpora within the shaft. So it's kind of an atypical location for a mass that would be considered to be a carcinoma. Okay. Here were the pre and post contrast imaging of the mass, and notice that it's kind of hard to see on T1, but on post contrast imaging, it's very clearly seen, and it's very vascular, especially in the periphery, with some central non-enhancement, which would suggest necrosis. Again, it's proximally located, it's eccentric, and at the level of the corpora. At this point, the patient went on for further evaluation with a chest X-ray, which failed to show metastatic disease. They are also planning to have a PET CT, but with some issues, they decided to defer it until after surgery. The patient eventually went on to total penectomy. Okay, so here are the surgical specimens, and you can see both unsectioned and sectioned images of the penis. You can see that there is this red area here. Those are the blood-filled spaces of the corpora. And then here is that mass, which is heterogeneous in appearance, kind of yellowish or orangish in color, with some areas of internal necrosis, just like we saw at imaging. At pathology, here is a low power view, and you can see that the mass again is located here within the corpora, rather than your typical location at the distal penis. On a higher power view, you can see the tumor cells range from epithelioid all the way to spindled with a sarcomatoid type appearance. There are also areas that are less cellular here because they represent necrosis, like we saw with the pore enhancement at MRI. Now, because of the fact that this was really kind of an unusual and poorly differentiated tumor, and it seemed to be multifocal and in the corpora rather than at the distal penis, the pathologist did an extensive panel of immunohistochemical stains, most of which were negative, with the exception of two. Okay. One that was positive was PAX8, which we commonly associate with renal malignancies. Okay. Um, and then there was a second marker which can be seen in a variety of tumors, including colonic adenocarcinoma, that was also positive. Okay, so eventually the patient went on and had their PET CT, and we have the CT images from that PET CT. Okay, and I want you to notice here that the normal left kidney is missing. Instead, we have a left pelvic kidney. Okay, but that kidney is abnormal, as you can see on these images. There's this large heterogeneous expansile mass coming off the left kidney. There's also associated retroperitoneal adenopathy, as well as interval development of bilateral inguinal lymphadenopathy. Okay, so atypical location of the mass, PAX8 positivity, and now the development or the identification of a renal mass. And if you put that all together, this actually turns out not to be a primary penile tumor. It's actually a secondary tumor. It's a metastasis to the penis from a clear cell renal cell carcinoma. So thank you very much, Christian Kingeter from University of Kansas for submitting this, very interesting and challenging case. I think it really highlights the importance of putting both putting the clinical, the pathological, and the imaging findings together to get to the ultimate correct diagnosis. And here's just our collage of images together. So congratulations on winning best. I want to take a second. Dr. Manning has been with the AIRP for a long time now. I don't know if I should say how long, but I was a fellow back in 2013 when you were starting in the GI section chief role. And Dr. Manning has been a major influence on me over the course of my time at the AIRP, starting from teaching me all the way to just being a model of what a section chief should be. Um, Unfortunately, she has decided to step down as section chief of GI, but fortunately for us, she's passing it off to an excellent radiologist to follow in her footsteps. Dr. Megan Lubner will be starting in that role in January. Fortunately, I think Dr. Manning is going to continue to use her considerable talents to lecture in the course moving forward. So I just want to take a second and thank you for all your contributions. You have a plaque coming to you. Uh, um, but thank you very much.
Thank
You want
you.
to say something?
Um, Thank you. Thank you very much. That was absolutely unnecessary, but I do appreciate it. This has been really one of the highlights of my entire career is working at the ARP and having the benefit of teaching all of these amazing attendees who are so excited about learning and honestly deepening my own understanding of rad path correlation, which has made me a better radiologist, and having the opportunity to work with such amazing colleagues and now friends. So it's been it's been a wonderful experience for me. And I'm so excited for Dr. Lubner. She's going to be amazing in the role. I have zero doubt, and I know it's going to be a great experience for her as well. So thank you very much. I don't want to take up too much time, so because I know we have a bunch of great cases to look at, but thank you. Thank you for saying that.
Okay. I'm going to pass it off to Dr. Kuzmiak if you would like to take over and do the breast case.
Can you see my screen?
Yes, we can.
All right, thank you very much. And I echo what Dr. Marco had said. There was a tremendous interest of cases this time for breast. Some really fascinating things, but I had to pick one. But thank you everybody for taking the time and the effort to submit these cases. All right, the best breast case. All right, so for the clinical information, we have a 43-year-old male. He presented with a history of a slowly enlarging non-tender mass in the right breast. Here's a picture from his physical exam, and you can see this about 4 centimeter fungating, kind of fleshy red mass. It's kind of displacing that nipple areolar complex a little bit laterally. There was no ulceration here of the tissue, and also there was no adenopathy on physical exam. He underwent mammographic imaging. Here is the right breast, and you can see within that retroareolar region, we have this at least 4 centimeter circumscribed mass. There's associated calcifications. There's a little bit of skin thickening as well. This lymph node looked prominent but was normal. I want to show you an enlarged view here. So you can see these calcifications just look very strange. Are they pleomorphic? Are they dystrophic? For those of you who will eventually be doing oral boards, so some things to consider, is this maybe infectious? Is this something chronic? He wasn't red hot or tender on physical exam. Maybe this was fat necrosis and some calcifications, no history of trauma. Is this an epidermal inclusion cyst in that you just have some keratin debris that's calcified? I want to point out this is not nodular gynecomastia. Nodular gynecomastia is not going to displace the nipple areolar complex. It's not going to cause skin thickening or have the calcifications. So it's a male patient. What else? Well, malignant things could be an invasive breast cancer, no special type, maybe a papillary lesion. Could be a solitary met. Maybe he has colon cancer, maybe a papillary thyroid cancer, or maybe it's a rare osteo or chondrosarcoma, which are, rare in women and extremely rare in men. Patient went on to ultrasound. We have this 4 centimeter circumscribed mass. You can see it's adjacent in involving the skin. We have some skin thickening. It's very heterogeneous in appearance. You can see the bright calcifications. We're getting that shadowing. It's hard to see internally what's going on because of the calcifications. There's a little bit of internal blood flow. There's predominantly peripheral blood flow. Don't see a track like an epidermal inclusion cyst to go up to the skin. Patient underwent biopsy, and on histology, there is a biphasic lesion here. And along the periphery, we have these monomorphic, very small, uniform, deeply basophilic cells. So here's high power of these peripheral cells. And in the central portion of the lesion, there are these anucleate eosinophilic cells. Here's a medium power, and some of these anucleate cells are containing calcifications. Gross pathology, just beautiful example here. There's 4 or 5 centimeter circumscribed mass. You can see it's displacing the skin here. It's kind of fleshy tan in color. There's some focal areas of hemorrhage, but then we kind of have this chalky white, very gritty material, which are the calcifications. So this is just a beautiful rad path correlation you can see from the gross, and it certainly explains what we're seeing on imaging. All right, so the diagnosis is a pleoma trichoma in a male patient. What is this? It's a benign tumor originating from hair matrix cells. On histology, we had those peripheral basal cells and that central anucleate eosinophilic ghost cells. Epidemiology, usually seen in younger patients. More commonly, it's in the head and neck and extremities and trunk on children. Extremely rare in breasts. Clinically, slow growing, painless, firm dermal based mass. The imaging is variable. Always note though, it will be dermal based. It won't be in the central portion of the breast. Treatment is excision. The prognosis is excellent. So the best breast case is a pleoma trichoma in a male, submitted by Monica Casavan from Boston University Medical Center. Thank you so much for presenting this fascinating case. I have never seen anything like this before, and I even showed it to Dr. Harvey, who could not join us today. She had never seen this before as well, so certainly a best breast case. Thank you.
All right, that was amazing. And next case is going to be our GI case. I think you're, Dr. Lubner, I think you're going to be doing that one today.
Yes, good morning. Hopefully everybody can hear me. I just wanted to echo several of the earlier comments. One was we had some amazing GI cases submitted, so thank you so much for your time and effort. It was very hard to choose a best case because there were so many great ones. I did want to echo what Dr. Marco said. We are now publishing the best cases of a given year in R3. There is a little bit of a delay between your course and the solicitation of the manuscript, so please do keep an eye out for that. And we would love it if your case could be included when the time comes. I also wanted to give a huge thank you to Dr. Manning and echo Dr. Marco's statements. She's just such an amazing teacher and contributor to this course, and it's been such a privilege to work with her, and I've learned so much, and thankfully she's going to stay on as a faculty member and continue to mentor me in this role that she's done such a fantastic job in. So without further ado, we'll look at our gastrointestinal case. And this was a case, this patient had a little bit of a complicated history, so I'm going to try to summarize it here, but this is a 57-year-old man who initially presented with abdominal and left flank pain, came in, looked like he had some bleeding, which I'll show you, and was treated for the bleeding, but left AMA because he wasn't sleeping well, was having back pain in the hospital. Returned 11 days later with worsening right upper quadrant pain, but now also with fever, night sweats, and pretty prominent weight loss. And so this was his original imaging when he first presented. This is a multi-phase CT, non-con, arterial, and a little bit more delayed phase imaging. And you can see that he's got this heterogeneous crescentic collection in the spleen. So it looks like a subcapsular hematoma, which was probably the source of his initial left-sided pain. But you can see that when you look at his liver, that he's got multiple somewhat vascular appearing lesions. They're fairly numerous. There's greater than 10. And you can see that they appear to show some nodular peripheral interrupted enhancement that seems to fill in a little bit on our delayed phase imaging. But not everyone shows this pattern. So at first glance, we say, well, these are vascular lesions. Maybe these are multifocal hemangiomas, but they're somewhat numerous and some are slightly atypical in appearance. And so subsequently on his second presentation, he got an MRI, which unfortunately was done without contrast because the patient was not doing well. But you can see this is a collage of MR images. And on T2 weighted images, these are fairly high in T2 signal intensity and have a slightly lobulated margin like you might expect a hemangioma to look, but they also have a sort of targetoid appearance with some lower T2 signal intensity material in many of the lesions. Some of these areas look a little nodular or irregular. Maybe there's some high intrinsic T1 signal intensity in some of these lesions, and some are showing restricted diffusion. Here you can see that the liver looks enlarged and that these lesions are very numerous. So the patient underwent sampling, which showed some blood products, but also showed evidence of infection. And his clinical course, he continued to decline and unfortunately did not survive. And on autopsy, you can see his liver has multifocal kind of violaceous lesions involving both lobes, very numerous, as we saw on imaging. And on cut section, you can see kind of why they had that appearance, that targetoid appearance on MR. I think I have a side-by-side picture here that many of them have sort of a rind of bloody or hemorrhagic appearing soft tissue. Some contain some central blood products, which may be accounting for some of the targetoid appearance. And you can see how numerous these are. So clearly vascular hemorrhagic lesions that are multifocal and somewhat atypical. When we look at the histology, on this left side of the slide, you can see some normal liver cells. Here you see this lesion that's got a lot of red in it, so a lot of hemorrhage, some atypical clusters of cells, and then a lot of vascular appearing cells. So as we mag up, here you can see that there's all of this hemorrhage that we saw in imaging, but also these clusters of very atypical pleomorphic cells. And special stains, especially for endothelial markers, were positive. And so this turned out to be a hepatic angiosarcoma. And this was submitted by Ryan Smith from Halifax, Canada. Thanks so much for this contribution, Ryan. This is an unusual malignancy that we don't see very often. Um, and because they're so uncommon, sometimes it's hard to tell what the typical appearance should be. Um, this does tend to present in male patients, although it's very rare. Usually they're in the 60 to 70 age range. Overall, a very poor prognosis that can be rapidly progressive, as we saw, unfortunately, in this case. This is one small case series that we participated in. There were about 35 tumors, and you can see these are some examples from our case series as well, have kind of a similar appearance. So often some high T2 signal intensity, kind of a lobulated margin, but really doesn't look like your typical hemangioma on T2 weighted imaging. You can see these peripheral areas of nodular enhancement that seem to sort of fill in, but again, the lesion is fairly large and bizarre looking. Here's another one. Again, these lesions in our series and in others, the dominant lesion is often quite large. This one was over 10 centimeters. You can see there's that intrinsic high T2, but this very atypical appearance peripherally. Here's some CT images from our series. You can see some of these kind of look like the case submitted with that nodular peripheral enhancement, but especially the bottom panel. These tend to be multifocal and can be very numerous, often grow quickly, can present with metastatic disease, as we see in the middle panel, and about 40% of patients have some underlying liver disease. This is a case from the archive. This was in a pediatric patient, a 2-year-old. And again, you can see large multifocal vascular appearing lesions on CT, kind of that targetoid appearance on ultrasound with pretty exuberant contrast enhancement on contrast enhanced ultrasound and MR. And again, you can see these lesions that have a lot of hemorrhage in them, some blood vessels, and then atypical pleomorphic cells, again, staining positive for our endothelial markers compatible with angiosarcoma. So a beautiful case with great red path correlation. Thank you so much, and congratulations, Dr. Smith.
Oh, that was awesome. Let's continue the awesome cases with neuro, if Dr. She's available.
Good morning, everybody. Is my audio okay?
Yes.
Okay, let me share. Kind of feel like we say the same thing every single course where we are blown away by the cases you submit to us, and we can all only pick one. But, just off the top of my head, we had beautiful cases of neurocysticercosis, a beautiful JNA. Actually, had two submissions of tuberous sclerosis, cortical tubers, but ended up picking this case for this particular course. This is a pediatric case with a young infant, 2-month-old female with a rapidly growing left maxillary mass. And I'll stress that that is a very classic history for this very rare entity. And on the CT, you can see how it's kind of coming out of that left maxillary alveolar bone, how it's expansile. And the parents could even note it was growing over, for example, the course of a week to give you a sense of how rapidly growing. I mean, the kid is only 2 months old. So let me move on to the next set of images. These
Minimal
are some.
urothelial thickening and enhancement period, no focal.
Can you mute? Okay, thanks. Here is the reformats, kind of the panoramic view that we sometimes get on our facial CTs, showing its relationship and how it's kind of displacing the teeth around. And here it is on the 3D, a little bit harder to see in the 3D. So of course, we're suspicious for a tumor. And we're going to pursue MRI with and without contrast. On the left is an axial T1. In this case, it's either ISO or maybe has some very faint specks of hyperintensity within it. On T2, it's also a little bit heterogeneous. I mean, some parts are a little bit brighter, some parts are a little bit darker. And on the post-con, let me put my little zoom panel out of the way here, is it shows some enhancement with it. So kind of confirming that we're thinking this is a vascularized neoplasm, right where the skin marker is. And I'll show some coronals. Oops. Here is the kind of matches that panoramic view from the CT, showing how it's coming from the left maxillary alveolar bone. And again, growing rapidly. The imaging features themselves are not super specific. If you think there's some mild T1 hyperintensity here, that might be a clue to the final diagnosis. In a kid, you might be worried about metastatic neuroblastoma. You might be worried about leukemia lymphoma. You might be worried about rhabdomyosarcoma. This will turn out to be a more rare entity. Here is the gross specimen. So it was about 3 centimeters in size. The surface of it was kind of pinkish white, which is nonspecific. But when they sectioned it, you could tell that it was a pigmented tumor, that there was this blue-black discoloration that is suspicious for melanin. And here is a low-power H&E photomicrograph of the tumor showing the classic histology that we see with it. It's biphasic, meaning we have two different populations of cells. So I'm going to highlight the first population, which are these small round blue cells, like here in these nests. And because they resemble neuroblastoma, sometimes we refer to this as kind of a neuroblastic cell population. And then the other population are these cells which have more cytoplasm in them. And also, if you stare carefully, have kind of this brownish pigment too. So these are a more epithelioid cell population, and that pigment again is melanin within the cytoplasm of these cells. And then all the pink stuff in between these two cell populations, that's collagen and fibrosis. So very classic histology of neuroblastic cells, pigmented epithelioid cells in a fibrous background. Don't intend for you to read all this. It's just a photo of the path report. Again, talking about that classic biphasic histology. Here they talk about neuroblastic and neuroectodermal type cells, but that is just another way of saying the epithelioid second cell population. And so the tumor that this will turn out to be is a rare. I checked in our AIRP archives that we have this will be our third one, rare pigmented, locally aggressive craniofacial tumor of children, infants. It usually presents in the first 6 months of life. It's quote unquote benign, but it is locally aggressive. So the mainstay of treatment is surgical resection and have to watch for a recurrence, which is not uncommon. This thought to be of neural crest origin. In fact, some of these tumors will be associated with elevated VMA, just like neuroblastoma, elevated catecholamine metabolite. So what is this tumor? This is a melanonic neuroectodermal tumor of infancy, sometimes abbreviated MNTI. The old name for this is melanonic progonoma. So MNTI classically presents as a rapidly enlarging craniofacial mass in a young infant and has that typical gross and histopathology. So thank you very much, Dr. Lester, for your submission from Austin.
Wonderful. Super rare, huh? 3 in the archive. That's amazing. Okay, congratulations. We're going to move on to the cardiothoracic case next. Dr. Frazier.
Hello, everybody. Yes, again, thank you all for your efforts, and it's always hard for us to find the best case, but we are so appreciative of the effort you put in. And I also want to shout out to my good friend and long ago, my former resident, Maria Manning, who always, from the very beginning of when I knew her, had such tremendous intellect and commitment to great communication and great education and innovation, and has far surpassed anything I've achieved. And I'm just so proud of her. So well done. Okay, well, here we go. So this case was from a 50-year-old male presented to an outside hospital and then was transferred into the hospital where the resident was training. But he was initially presenting to an outside hospital with 3 days of left chest pain, chest pressure, and a cough. And based on the CT findings, he was then transferred. And I unfortunately don't have the chest radiograph, but I have coronal and sagittal reformats. And this is one of those tough cases that, we always take these, or at least I do, take this as an unknown first without an answer and see what I would have said. And, when you see something so large in the chest like this, and seems to cross a fissure potentially on the sagittal reformat, you are challenged. You are challenged to know what compartment is this actually arising from? You know, is this arising from a pleural line of cells? Is this arising in the lung? Is it potentially in the mediastinum, although I would not have chosen that. But I think I would have been a bit challenged at this point to say, if I was sitting with my clinicians, very large, sharply circumscribed, ovoid mass-like opacity seems to, for me, exert mass effect upon the mediastinum, so suggesting it's extrinsic to that. Also seems to exert some mass effect upon adjacent lung parenchyma and left upper and left lower lobes. Appears not to have aggressive features of local invasion, appears to have some internal character that is relatively homogeneous. And this is a selected image axial cut. And, you know, it does show that mass effect upon the mediastinum, although there is some mediastinal fat which could be stretching around it. But just looking at the internal character, when I looked at this, you know, it doesn't have a complicated appearance within it at this point. It looks rather homogeneous. It looks low density. It's probably fluid. The margins are not enhancing. There are no internal septations. The margins themselves, again, are not nodular, and there doesn't seem to be invasive features. It was decided to help the clinicians decide what to do next. They attempted to drain this. So what would your differential have been? I mean, I would have started with, is this an unusual abscess? Is this an unusual form of a lung cyst, like a bronchogenic cyst in a strange location? Is this a strange cavitary lesion? But a cavitary lesion that is pulmonary is going to usually almost always have gas in it. Is this a neoplasm that has like a myxoid or low density cellularity to it, and I'm getting fooled into thinking it's fluid? So there were a lot of things I was thinking about. It doesn't have ancillary findings of, for example, adenopathy, pleural effusion, and again, invasive character. So whatever this is, it's rather circumscribed and limited. So they drained it to get some fluid for diagnostic purposes. And it's interesting. It drains, it fills immediately with gas, which what does that mean? It means that it's connected to the tracheobronchial tree, which again, at this point, I'm thinking, okay, if it's filling with gas despite the drainage, it didn't totally collapse. That means it's in the lung or has secondarily involved the lung. What's interesting also is look what these contents are that was not appreciated on the pre-drainage picture. It's all these kind of folded linear densities. Shortly after they drained it, according to the notes, the person developed a very large left-sided hydropneumothorax and left lower lobe near complete collapse. So in addition to a pigtail drain that they placed in the primary lesion, they had to put in a large bore chest tube, which you can see sitting at the left apex now. So that large hydropneumothorax was reduced. And the effusion, I do not see a significant pleural effusion. So what I'm looking at here is this large air-filled structure with multiple internal folded densities. Now, they knew the diagnosis based upon the fluid that they drained. Ultimately, this was removed. A left upper lobectomy was performed. It was successfully localized after thoracoscopy to the left upper lobe, and then a left upper lobectomy was performed. And this is the surface anatomy on the left, which is largely the lobe, which is, but within that lobe, we can see a very dense outer fibrous capsule, which was sectioned here in the lower right. So it's really great to have these pictures to show us what were we really looking at on the CT imaging. So there's this thick outer rim, and this was what was sort of folded inside. It was kind of like a sheet of tissue. It had a sort of chitinous, but it also had some complexity to it, some nodularity to it. And this is what we would call an endocyst. The outer heavy capsule was what we would call a pericyst. Maybe that's beginning to ring a bell. And when they did histology, we have the H&E section. This is a low power H&E. We can sort of get an overview of a multi-laminated or multi-layered structure here. So to the far right would have been the internal lumen of that fluid-filled lesion. And then immediately on the inner lining where that inner folded membrane is, that was an endocyst layer. This is really the nursery of protoscolices and brood capsules, daughter capsules also called. And the fluid is something called hydatid sans. Okay, so this is a hydatid cyst. So the endocyst layer is the germinative layer that's really responsible for setting up a nursery of asexual reproduction for protoscolices and so forth. And then there's kind of that chitinous layer I mentioned, which is called the ectocyst, which is a purely laminated layer. And that would be PAS positive. Those stains were not done here. And then a pericyst. Now, the pericyst is the outer fibrous capsule of this lesion, and the pericyst is actually not produced by the hydatid microbe. It is actually produced by you, the host, to try and vigorously wall off this infective process. Okay. And then adjacent to that is what I've written down as adjacent chronic lung inflammation. So this didn't arise in a week or two. This is kind of a smoldering form of an infective process that usually takes months to appear, as it did when he presented. And he had a cough. He did not have a productive cough. If we go to a higher power view and we look at that endocyst layer, we can see that this is transected pictures that I circled of the larval heads, which are the worm, right? And we can look here at the protoscolices, and they are kind of swimming in the hydatid sands. And this is the nutritive or germinative layer. And we look here and we can see hooklets. So my arrows are now pointing to those rostral hooklets that are also often being shed into the hydatid sands, but they're ultimately, I think, designed along with the sucker material on the top to where the ultimate, more mature form would be able to attach to, for example, intestines. So this was a very nice case, beautiful case of Echinococcus granulosus hydatid cyst centered in the left upper lobe. And the question in the back of your mind might be, well, you didn't show us any pictures of the liver. What's going on with serology? And there was actually no liver disease at all in this person, and the serologies were negative. So sometimes we have to be sharp in the imaging world to say, I am looking at most likely a hydatid cyst, and then they know to go in and get direct tissue and fluid sampling of the lesion itself. So we do have a role to play because a proportion, up to a third of all cases of hydatid cysts in the lungs will have negative serology. In fact, even liver and lungs will have negative serology, so don't be fooled by that. This is an infection that can be acquired in any part of the world, not just in remote areas. Okay, so it's important to know that, to recognize that. There are endemic areas for sure, but it's actually even in North America, in Europe, and so forth, not just remote areas. Dogs, the definitive host. We are not a definitive host. We're sort of an endpoint. And so once we get this infection, we are not going to pass it along to someone else. Okay. But would get it by infected feces, for example, food preparation and so forth. Now, yes, 70% of hydatid cysts arise in the liver and are present in the liver for infection, and lung is secondarily involved, but there are cases where there's isolated lung, heart, breast, brain, peritoneal infection. So pulmonary wise, lung is actually the second most common affected organ. I have about 4 cases from my own practice up at the University of Maryland, people that have come in with this disease, that fluid-filled structure, most often solitary. Initially, you can have a differential diagnosis and scratch your head, and you may not observe that internal multi-layered structure until it is ultimately drained. That's exactly what's happened in every prior case I've seen, where you didn't really appreciate those fine linear layers of endocyst. Okay. Complications can be things like cough, yes, but you can also end up with hemoptysis if it's invading an airway or a vessel complex, anaphylaxis if it ruptures, empyema if it ruptures, pericardial tamponade, dysrhythmias. I have a couple cases of cardiovascular echinococcus as well. It interrupts conduction pathways, tension pneumothorax, hydropneumothorax, something like this person also suffered from. So treatment options were, as he experienced, puncture, aspiration. In our institution, they've also injected the antiproloscolecidal agents and re-aspirate. But ultimately, this is usually a resected lesion when it's in the lung, and these people do very well. So thank you to the resident that put this together for us, Angelica Gordon from the University of California, Irvine. Thank you so much.
So we don't usually do best of the best, but that was pretty good.
That was pretty good. I love it.
And it's usually an
Hey.
abdominal thing, so it gets bonus points.
Absolutely. I do
Yeah.
love it when it's in the lungs. Sorry, but I do.
Yeah. Congratulations. That's amazing. Okay, now we're going to go on to Pete, Dr. Biko.
Yes. Hopefully, for some reason, my camera is not coming up, but you can hear me okay?
Yes, can hear you well.
Okay, good. My camera suddenly stopped. I think I'm having a little bit of a connection issue. Hopefully, I can get through this. But thank you, everybody, for submitting pediatric best case. And again, let me know if something goes wrong and you lose me, but hopefully you will not. This is the pediatric best case. This is a 3-year-old female presenting with a month of intermittent severe abdominal pain, along with lip and oral mucosal freckling. Oh, there I am. Good. Nice. Here is, this patient went on to have a CT. Here is the CT examination, axial and coronal. And as we come down through the axial from superior to inferior, we initially see this dilated bowel here in the left upper quadrant. And we have this telescoping appearance of the bowel as we go. Interesting enough, right, when we think about this, which looks like an intussusception, it looks like it is in the small bowel rather than the colon. The colon is separate from this. So we see the colon kind of posteriorly next to the kidney there on the left. So we have a large small bowel intussusception, which we're not commonly seeing when we don't commonly see this, right? We usually see these small bowel intussusceptions, which resolve on their own. Here it is on coronal. And we see this intussusception here in the left upper quadrant, this big dilated bowel with this obstructed area, this telescoping appearance and thickened bowel. Now, if you notice here centrally, when we see something like this, we have to immediately think about a lead point. So if I see this, whether it's on an ultrasound or a CT, the next task I'm doing is I'm looking for a mass. And sometimes you can't find the mass, but you should be looking for a mass, particularly if you have a large small bowel intussusception. And I froze it right here, and you can see there's this kind of lobulated lesion here within the small bowel. And as I move on, here is, again, that intussusception. And then we have this lesion here within the small bowel as a lead point for this intussusception. Luckily, in pediatrics in a 3-year-old, often these are benign processes. We think about other more malignant processes in an older patient, such as lymphoma. In a 3-year-old, most of the time these are benign processes causing these intussusceptions. But regardless, this is going to have to be resected, which it was. And here we have this lobulated mass along with this piece of bowel here. And here is the surface cut showing this lobulated mass. This kind of polypoid type lesion, which I'm giving away the diagnosis of a mass. So this is the histology, the H&E stain, and it shows that normal jejunum that came out with the mass. So we've got the columnar epithelium with some goblet cells and the muscularis mucosa. in the normal jejunum. But within that jejunum was this hamartomatous polyp. So if you notice, there's this villus architecture of a hamartomatous polyp. We've got these these villi is what we commonly will see. And then we see these deep, small muscle layers deep to these villi. Additionally, which is not that common in these hamartomatous polyps, this one had ectopic gastric mucosa. We have these gastric glands, and additionally, it had ectopic pancreatic tissue, including these intercalated ductal pancreatic tissue, and an interlobular duct pancreatic tissue. So not just a hamartomatous polyp, but gastric mucosa within this hamartomatous polyp, which I have not commonly seen. So this brings us to hamartomatous polyposis syndromes in children. So in a 3-year-old, I immediately think about a syndrome where you can have an isolated polyp, but you have to start thinking about syndromic causes, including that this patient did have this freckling, if you noted in the history. So what is our differential? Well, we have a juvenile polyposis syndrome. Here, most polyps are in the colon rather than the small bowel as in here. There is increased risk of colorectal cancer, and it's autosomal dominant inheritance. We have the phosphatase and tensin homolog, the P10 homologs, which are autosomal dominant or isolated. And this includes probably something you may have heard of, but I personally have not seen, Cowden syndrome, which is macrocephaly, along with mucocutaneous lesions. But these are trichomoniasis, which are kind of these raised things on the face, not freckling. And then BRR, or Banyan-Riley-Ruvalcaba syndrome, which has developmental again, macrocephaly and lipomas. And then finally, we have Peutz-Jeghers syndrome, which is autosomal dominant. There is an increased risk of GI and extraintestinal cancers, and this patient they also can have mucocutaneous pigmentation. So just to show you an example, this is from old article from a imaging clinical medicine of Peutz-Jeghers syndrome, as we don't have on this case, we don't have the actual image of the patient, but you can see there's that freckling, along with that freckling on the lips, and this is what you would commonly see with Peutz-Jeghers syndrome, and that's what this is. Just wanted to show you a companion case. This is a juvenile polyp, again, a hamartomatous polyp, but this was in a 25-month-old that I have from my institution. And I think, I wanted to show you this because I wanted you to see how these polyps look like on ultrasound. And you notice on ultrasound, you really get a lot more fine detail on high resolution ultrasound, especially in children. And this is a 25-month-old, a very small child, right? We can get high resolution images of these children, but you can see how we have these echogenic stripes, and you can almost picture that this has this kind of polypoi or these papillary projections coming from this center core in this hamartomatous polyp, not Peutz-Jeghers syndrome, but in this hamartomatous polyp. This patient did go on to have an MR, where again you can see that on the MR where you can really see the architecture of that hamartomatous polyp here in the right upper quadrant. It looks a lot bigger actually on the MR on this projection than on the ultrasound. In this patient, you can see it also has an intussusception heading to that polyp. So this is a hamartomatous polyp, and this is an intercepted hamartomatous polyp in Peutz-Jeghers syndrome. And congratulations to Anish, I don't know if I'll hopefully pronounce your name correctly, Karlapudi from Indiana University School of Medicine. Thank you so much for submitting the pediatric case, and I hope everyone enjoyed the course.
Congratulations, another amazing case. Okay, the last but not least is the MSK section. Dr. Murphy.
Yeah, Opsy, if you can run it for me, that would be great. I'm off site, and I apologize for that, not being able to attend the whole meeting. I did want to give a shout out to both Doctors Harvey and Manning for their incredible service to the ACR, and the ACR Institute for Radiologic Pathology has been just fantastic working with them, and I'm so happy that Dr. Manning is going to be staying on as the Associate Chief of GI. So just fantastic teachers, as you all know, and they've just done just a superb job over the many years. So just a shout out and thank you to them. All right, so the musculoskeletal case. Next, the summary is shown here. It's a patient with right lower extremity fracture, and then she had new onset of a lump in her thigh that felt different than before. And what we identify, go ahead and advance, is this mass in the upper calf, and one can see it quite nicely outlined by the arrowheads. Next. We can see the mass is intermediate signal to a little bit higher signal than muscle on the T1 weighted image. Next. And it's definitely high water content, as you can see on the water sensitive sequence. Next, but if we advance, we can see there is focal nodular areas of enhancement in this lesion. Go ahead. On the long axis images, we see similar features. Next. With that high water content mass, a little more nodular enhancement on the post-contrast study. Next. Again, so intermediate to higher, a little higher signal than muscle on T1 weighted images. Next, very high signal intensity on the T2 weighted image. And on post contrast, we see more nodular enhancement than perhaps we saw on the axial images. So clearly a solid but high water content mass. Now, you might initially think that this was intramuscular, but in fact, if you really look carefully, it's probably splitting the tibialis anterior, which is more medial, and the extensor digitorum, which is more lateral. So it's likely to be an intermuscular mass, and that just gives me my broader differential diagnosis, and we've just kind of outlined it there in this particular example, that it's really splitting those two muscles, and that's why there's a little fat around it also. Next. And there, so this intermediate signal intensity mass. Keep going. And again, high water content, as we can see here. Now on these images, we can see the mass again with that splitting of the muscle. Go ahead and advance it. And there is the muscle around it. And one more image, we've just drawn a little area where it's really split between the two muscles. So we'd go down a general differential diagnosis for intermuscular masses that are also high water content. Advance. But if you look, there's actually small areas within it that are higher signal and around it as well, which really suggests fat. And that's pretty convincing when we look at our fat suppressed sequences, because those areas that might look like septations have too high a signal intensity and they're fat suppressing. And it may be a little more convincing on the long axis images. So if you'd advance, so again, we can see multiple areas that are a little small foci of high signal. So now we have a high water content mass that's intermuscular that contains a very small amount of fat, which is relatively diagnostic. Here we see the high water content on the gross specimen. It's very myxoid, very high water content, as you can see on this sectioned gross specimen. And I think we just have stars identifying that. Advance. So on the microscopy, this has very characteristic appearances. Next, all the blue around those areas, that's the high water content myxoid tissue. Next. And then we can see small lipoblasts there also. So there's a small component of fat. And then next to the typical, what's been described as chicken wire vascularity and small vessels as well. All of those features are really characteristic of this particular diagnosis. And here just a compilation of all of the findings that we saw. And again, those findings are really diagnostic of myxoid liposarcoma with pretty subtle fat that you have to step back and really pay attention to also. So advance. And so this is a beautiful case of myxoid liposarcoma in the soft tissue given to us by Dr. Christian Huevos from the University of Wisconsin in Madison. So go, Dr. Lubner. Thank you. And I just wanted to see if Dr. Smetherman would like to say a few words. I know she's on, and we thank her for her attendance.
Well, thank you for letting me join you. This has just been so much fun to see these amazing cases. So really, really enjoyed it. And I'm sorry I wasn't able to be here when this cohort started. So I'm glad to be able to join you here at the end. I hope that all of the learners have really enjoyed this wonderful opportunity to work with this great faculty that we are so fortunate to have. Special thanks, of course, to Doctors Harvey and Manning. Glad to hear Dr. Manning will be continuing to be part of the course. And then just thank you to all of the faculty and the advisory committee for all of the hard work that you do during the courses and between the courses and all of those things. And also congratulations to our winners of the best cases. Just amazing pathology. Hard to pick a favorite. And then finally, of course, thank you to Dr. Marco and Dr. Murphy, our fearless leaders, who are always here. And of course, Don Hatley and the ACR staff, who make all this possible. So again, just so delighted that I was able to join you guys today and see a little bit. It was nostalgic for me as a former when it was AFIP attendee. So, all right, have a great day, everybody.
Well, thank you so much, and thank everybody for all of their hard work. Your cases are amazing, and as all the section heads has mentioned, it's really difficult to pick a best case. Jamie, Dr. Marco, do you want to say any last
Nope.
words?
I think we covered it all. Thank you again. What is next on the schedule?